Hi, everybody. I'm here for New Macro Media tonight. This is Joe Firestone with the In Depth Show. Please bear with me while I share to a few places. I'll be back shortly. Okay, sorry to be so long. Oh, wait, I got to make an adjustment yet. Ah, Okay, sorry to be so long. Oh, wait, I gotta make an adjustment yet. Sorry, I had to get rid of all the echoes. Thank you for coming. Oh, wow, thank you for coming. Howdy, Greg. Hi, Dale. Oh, I don't mind the South Park reference, Greg. Bonnie says hi. Greg joined and Barney joined, and I think a whole bunch of other people are here too, but I don't see you quite yet. I'm sure I will in just a little while. But hello anyway. Hello to all. Hope you're doing well this evening. I'm certainly doing well myself. So let's get started. Okay. I'm going to share something with you as soon as I get it on there. Here's a letter that was sent to Warren by the people at the Urban Institute. And they said, let's see, they said, here we go. Should be able to see it well now. Dear Senator Warren, we write regarding the impact of your Medicare for All plan on national health expenditures and federal government spending. We have reviewed prior cost analyses, applied existing research literature, and evaluated the specific policy features you have outlined. Based on our analysis, we estimate that your Medicare for All plan will decrease national health expenditures to just under the $52 trillion $52 trillion projected under current law for the 10-year period from 2020 to 2029, and will require new federal spending of approximately $20.5 trillion over the 20 to 29 the budget window. So, $20.5 trillion. So they're telling Warren that after $7 trillion in savings that she claims for her program, there will need to be another $20.5 trillion that will have to be spent, and the implication is that will have to be paid for, will have to be taxed in order to meet the anticipated spending under Medicare for All of $52 trillion. Now, of course, they have in mind here the likely costs for Senate Bill 1129. It would have been interesting if they had run some numbers as well on House Bill 1384 to see what kinds of different estimates they had for that particular bill, but they did not actually do that. Okay, so I read the Urban Report now, went through it today fairly carefully, and I went through this letter as well. And what I found to be a terribly big surprise was that the estimates from Urban would be $59 trillion from 2000 to 2029, assuming that we passed Medicare for All bill now, and that was applied beginning in 2020. Now, this, of course, is not a very realistic assumption because there's no possibility of passing a Medicare for All bill until 2021, and no possibility of it becoming effective before the first part of 2022 at the earliest. So we really should be looking at the period from 2022 to 2031, and not the period 2020 to 29. They give Warren credit that her proposed approach to actually negotiating drug prices and provider payments, and her claims about what she's going to do with administrative spending, what she's going to do about cost growth, would bring national health expenditures for the 10-year window to less than the $59 trillion they forecast. They specifically projected a savings of $7 trillion in health spending, so that it would become equal or just about equal to the no Medicare for All scenario, just the continuance of current law. For that, they took the 2020 to 29 projections of CMS, the Centers for Medicare and Medicaid services. And they projected $52 trillion in expenses, but under current law. Okay. And so the savings from Medicare for All that Warren got supposedly would only bring down their projected number for Medicare for All to just under what the spending would have been anyway, even without the Medicare for All bill. Now this seems to me to be outrageous, okay, and also ridiculous. Okay, now Warren has just accepted it as a reasonable sort, okay, of estimate, which I don't believe, okay, that it is. Okay, but anyway, they go on. They say our analysis also finds that your plan would require less federal spending than the proposal modeled by the Urban Institute. Furthermore, by implementing a maintenance of effort requirement for state and local funds currently spent on health insurance, your plan would obtain additional revenue of approximately $6 trillion compared to the proposal outlined, okay, by Urban. This brings the total federal cost for your proposal to $20.5 trillion compared to Urban's 34 trillion. I'm sorry, the total additional federal cost for your proposal. So that's how they get the 20.5 trillion. And they start at the 59 trillion. They subtract 7 trillion from that. They give her credit for another 6 trillion gotten from the states. She's then at 46 trillion. I guess that doesn't quite compute there, but I think they're right that the additional federal cost, given their numbers, is 20.5 trillion. So they give her credit for saving 34 trillion, but then say she has to make up, okay, another 20.5 trillion. So she proceeds to put in a whole raft, okay, of other assumptions concerning how she would pay for things through taxes, through fees, through premiums that would be paid by business, not by households. What she's trying to do, as you know by now, is to save the $11 trillion that households would pay under current law and shift the burden to other entities in the economy. Now, there were some other things that surfaced during this time. For example, Physicians for a National Health Program. I'm sorry. Should be PNHP. PNHP.org. David Himmelstein and Steffi Woolhandler, sorry. She likes to be called Steffi. Wrote a piece just after the Urban Institute study appeared. This was on October 16th. Let's see if I can easily locate it here. I should be able to. I should have lined this up for you, but it's on my other computer, and somehow in shifting over to this computer, I neglected to put it up there. But let me see if I can get it easily. Here it is. It's an article that was written by Himmelstein, and Woolhandler, who are doctors and who used to be at Harvard, and in fact they were at one point co-authors, of Warren's. They've co-authored certain things with her in the past. So you would think she would turn to them for cost estimates on what single payer is likely to cost, but no, she turned to Urban Institute instead. And they point to the new analyses of the costs of a single payer reform along with other reform options. And they say the Urban Institute posits impossibly large increases in the utilization, of medical care, ignoring real-world experience with coverage expansions in the United States and discounting the vast administrative savings achieved by single-payer systems, in other nations, and by the Medicare program here in the U.S. Their estimate that Medicare for All would increase health spending by $719.7 billion. Sorry for this adjustment. Here we go. Reflects these two incorrect assumptions. Now, when they're talking $719.7 billion there, they're talking about the estimated cost in 2020, from Urban. They say that Urban had an estimate that was too high by $719.7 billion. Over 10 years, that's probably given increases for some increasing prices. When you run that out to 10 years, it probably makes a difference of $10 trillion. But anyway, they say that reflects these two incorrect assumptions, which are hidden under layers of elaborate calculations, charts, and tables. Yes, that's right. It's very hard to find their assumptions, which allow them to arrive at this $59 trillion cost that the urban people reason from. It's very hard to find it. I looked very carefully for how they got to the $59 trillion. All I have out of their report, which is a very detailed report, something like 81 pages, I believe, is, we simulated this, and this is what our simulations show. And we took the $59 trillion that our simulations showed. We don't know what the assumptions are behind the simulations, of Urban Institute. All that we do know is that 59 trillion they're estimating over 10 years for a single payer contravenes and contradicts all the experience in the rest of the world about what happens when you switch to single payer. Anyway, they say we focus here on these two assumptions about single payer reform, but won't address the myriad deficiencies in the report's analyses of other reform alternatives, which systemically understate their costs and gloss over the fact that they leave tens of millions underinsured. There was, by the way, one good thing about the Urban Report that I saw. Urban admitted that under current law, there would be 34.6 million people that would be uncovered by insurance, that they wouldn't have essential insurance. This is the highest admission of how many people are uncovered that I've seen so far, in any report. If you take the 34.6 million and you divide by the ratio of 1 over 781, in other words, 1 in 781 people who don't have insurance die each year, you get an annual fatality rate which approaches 40 million people. So, 40 million fatalities. I'm sorry, got confused there. 40,000 fatalities per year. When we started out to do something about our healthcare problems during the 2000s, we used a study by Himmelstein, and Woolhandler. It was very popularly quoted, in the press, which showed that there were 45,000 fatalities per year as of the time they did a survey in 2005. They studied, they published their study in 2009, and then forever after, people were saying, hey, we have fatalities, in the neighborhood of 45,000 a year. That wasn't correct for some time after the passage of the Affordable Care Act. The fatalities were going down each year. But since about 2016, when the Affordable Care Act started to lose people, and since Trump has gradually started to undermine it, the fatalities have been going up again. And we now can estimate them at close to 40 million. So with all the effort we've put in on healthcare reform since that time, and all the arguments, and all the BS about it, we have only reduced the number of fatalities each year due to lack of health insurance by roughly 5,000 people. So 8/9 of the fatality problem still remains. Anyway, going on with the article by Himmelstein, and Woolhandler. The Urban Report assumes that single-payer reform would reduce insurance overhead to 6% of claims, $234 billion, from the current level of about 10.6. In contrast, overhead in Canada's single-payer system is only 1.8%, and overhead in the fee-for-service Medicare program is 2%. The Urban Institute Group justifies its 6% estimate by claiming that a single-payer system would require a host of administrative functions to effectively operate, such as rate setting for many different services, okay, and but also providers of different types, quality control over care provision, development, review, and revision, okay, of regulations, provider oversight, and standards enforcement, claims payments to providers, and other functions, unquote. But their claim, according to Himmelstein and Wohlhandler, ignores the fact that all of these functions are currently carried out by both Canada's program and fee-for-service Medicare. They never say why we would need 6% to perform functions that a system like Canada's or Medicare could perform for 2%. By the way, one reason why Medicare is at 2.3% now and not still lower is because of the advent of the Medicare Advantage programs, which means that Medicare has to deal with the Medicare Advantage insurers as well, which is not something they had to do before Medicare Advantage, and it's also not something Canada has to do. Maybe that's why they're down at 1.8% and we're at 2.3%. But that's just an extraneous thought, just a speculation. Anyway, administrative savings part 2. Urban completely ignores the huge savings on hospital administration and doctors' billing under a streamlined single-payer system. Every serious analyst of single-payer reform has acknowledged these savings, including the CBO, the Government Accountability Office, the Lewin Group, that's the consulting group owned by the that's owned by the United Health Group, and it was so important in pushing the public option farce in 2008 and 2009. It just about originated with the Lewin Group. Not the idea, but the political push behind it. Okay, the Lewin Group was instrumental in that. Okay, and they also mentioned, okay, the Political Economy Research Institute, which is the University of Massachusetts' Economics Research Institute, and even the RAND Corporation, which, of course, the Urban Institute is, if they look up to anybody, it's the RAND Corporation, you know. And they look up to Brookings and to RAND. Okay. Oh, no mention, okay, of Brookings here. Interesting. Anyway, these provider paperwork savings are in fact likely to be larger than the savings on insurance overhead. At present, U.S. hospitals spend 1/4 of their total budgets on billing and administration, more than twice as much as hospitals spend in single-payer systems like Canada's or Scotland's. Similarly, U.S. physicians who must bill hundreds of different insurance plans with varying payment and coverage rules spend 2 to 3 times as much as our Canadian colleagues on billing. And then Himmelstein and Wohlhandler point out these administrative savings for doctors and hospitals would amount to $250 billion in 2020. About $50 billion more would be saved by streamlined billing and administration of nursing homes, home care agencies, ambulance companies, drugstores, and other providers. So that's $300 billion right there. But they summarize for us. They say in total, the urban analysis underestimates administrative savings by about $450 billion. That's in 2020. Now, not counting increases over the years, okay? That comes to $4.5 trillion right there, they're talking about. Then Himmelstein and Wohlhandler get into the utilization of care idea. And they say urban projects a massive increase in acute care utilization. In other words, the use of acute care, based on its microsimulation models. They find, as expected, that people use more care when they get new or better coverage. But those models don't take into account the fact that society-wide coverage expansions face supply constraints that can't be discerned by comparing the utilization of the insured and the uninsured under the current system. The urban document does not provide breakdowns of how big an increase it foresees for specific services, for example, doctor visits or hospital care. However, overall, they project a 20.6% increase in spending for medical care, implying an increase of about 100 million doctor visits and several million hospital stays annually. Yet, there aren't enough doctors and hospitals in the United States to deliver that much care. Doctors are already working 53 hours a week, and careful analyses of experience in past coverage expansions tells us they won't increase their hours, nor will they see many more patients per hour. So there's not going to be a surge, in the utilization because the capacity is not there. No such surge was seen when Medicare was implemented and millions of previously uninsured seniors got the coverage in 1966. Between 1964 and late 1966, when Medicare was fully functioning, there was absolutely no increase in the total number of doctor visits in the United States. The seniors averaged, all Americans averaged 4.3 visits per person in 1964 and 4.3 visits per person in 1966. Instead, the number of visits by poor seniors went up, while the number of visits by younger, healthier, and wealthier patients went down slightly. The same thing happened in high schools, as we and our colleagues at Harvard recently documented. There were no waiting lists, just a reduction in the utilization of unneeded elective care by wealthier patients. And also the delivery of more care to sicker, poorer people who needed it. Moreover, the same dynamic occurred when the ACA newly insured, the Affordable Care Act, newly insured 20 million people, or when Canada implemented its universal coverage program. Neither hospitalizations nor physician visits increased. Instead of a huge surge, doctors and hospitals reduced the amount of unnecessary care they were delivering in order to deliver needed care to the newly insured. But the urban group chose to ignore the evidence from real-world coverage expansions that the limited supply of health professionals and hospital beds constrain the increases in the utilization. Instead, to support their assumption that supply constraints are irrelevant, they cite a non-peer-reviewed report from their Urban Institute colleagues who interviewed a handful of health administrators in 5 cities regarding their organization's experiences in the wake of the ACA expansion. That report never collected actual data on the number of visits or hospitalizations, either locally or nationally. The best evidence from past expansions indicates that the limited supply of doctors, nurses, and hospitals precludes a large surge in the utilization of care when coverage expands society-wide, as it would under single-payer reform. In summary, the UI analysis grossly underestimates the administrative savings under single payer and projects increases in the number of doctor visits and hospitalizations that far exceed the capacity of doctors and hospitals to provide this added care. Also, projections by many other analysts and experience in other nations that have implemented single payer reforms indicate that such reform would provide universal, comprehensive coverage while holding health expenditures steady or even lowering them. You got that? While holding health expenditures steady or even lowering them. That's been the experience, okay, in other countries. Now, let's go to some other experiences. Okay. So just to focus in on this chart, this is the Urban Institute chart showing the 20.5 that had to be picked up. This is the redirection that Warren spoke of. In other words, redirecting the state taxes to the federal government, covering part of the 20.5. And then they claim, Warren claimed minus $1.1 trillion based on slowing the cost growth of medical care over time. Then they gave her credit for the payment reform, okay, and the drug reform. I'm sorry, I'm doing this wrong. These are credits that go against their estimate of $34.0 trillion, okay, in additional federal spending. And they gave her credit altogether here for roughly $13.5 trillion. Okay. So what's driving up the total cost? How do you get to the 59 trillion? Well, you get there by the 25 trillion they estimate we're spending now, plus their estimate of an additional 34 trillion in federal spending. So they're saying, in spite of Warren's total of 13.5 trillion, there's still 20.5 trillion, okay, to go. So how could we lower the 20.5 trillion? Well, they're all the taxes, okay, that Warren offers, okay, to do that. Okay. But apart from that, we could lower that 34 trillion by showing that, okay, it's an unrealistic estimate. How might we show that? I know they ran their simulations, but simulations are only as good as the assumptions behind them, and we're never told what those particular assumptions are. But we do know this. We do know that the Centers for Medicare and Medicaid Services had estimated over 10 years that there would be $52 trillion in spending under current law. And we also know that between 2000 and 2029, that the percent of GDP, which they were estimating was going to be devoted to national healthcare spending, was going to rise from something like 18% in 2020 to 20% in 2029. So let's take a figure of 19% as the average, but for that particular period, of time. In other words, 19%, of GDP. Let's ask, what could we save if that 52 trillion. Okay, so the 52 trillion is then the product of the 19% of GDP on the average for that time that's going to be devoted to healthcare. So let's divide by the 19%. That tells us that the cumulative GDP over the 10 years that is getting projected right now, partly by CMS and partly by Urban, comes to roughly $274 trillion. It's over 10 years. That is the cumulative projection, of GDP. Now let's say instead of having spending at 19% of GDP, let's say through single payer, we could get down to Canada's level, which is roughly at 11%, of GDP now. So let's multiply by 0.11. And what do we get? We get costs for the Medicare for All program of $30.1 trillion if we can get to Canada's level of sheer efficiency in terms of percent of GDP spent on healthcare. Now, one might say, well, in our various plans, in the Jayapal plan, in the Bernie plan, there are transition periods. We can't expect to get down to the 11% of GDP for all 10 years. We might be able to do it from year 3 to year 10, but year 1 and year 2, it's going to be worse than 11%. Fine. So let's say the result of all that is to change the average to, let's say, an average of 12.5% over the 10 years. That brings up the cost, of Medicare for All, the total cost, of Medicare for All, mind you, to $34.1 trillion over 10 years' time. That's the total cost. Now, what Urban says, they agree with the figure that the federal government is already spending $2.5 trillion a year. No, I'm sorry, not the federal government, but at all levels of government, that our governments are spending $2.5 trillion per year in U.S. dollars on healthcare. Over a 10-year period, That's roughly 25 trillion. So at most, what Warren and also Bernie have to make up over a 10-year period in pay-fors, if we're assuming they're going to pay for it in the manner that people seem to like, but through taxation, the most that they would have to make up is roughly $9.1 trillion over the 10 years. A far cry from the $20.5 trillion. Right? Now, Bernie has specified various ways of funding Medicare for all. All in all, they total something like $16.2 trillion. Warren has proposed pay-fors different from Bernie's. I don't know how much overlap there actually is in that. She's proposed pay-fors of $20.5 trillion. So, there's no question that the $9 trillion can be made up. But why make up on the $9 trillion? $9 trillion over 10 years averages $900 billion a year. Well, how about this? Why don't we limit by the additional taxation to corporations, okay, and to the rich, okay, and keep it at roughly $450 billion a year? That will take care of roughly half of the $9 trillion, okay, that has to be made up. And the rest of it, $450 billion a year of it, we can deficit spend. If we deficit spend it, then it will provide some stimulus to the economy, which may be needed because there's a possibility that lowering anticipated costs through the Medicare for All program would be deflationary as opposed to inflationary. So, anyway, why should we believe that we can lower our spending as a percent of GDP to the same level as Canada? Well, why should we not believe it? What's so different about Canada from the United States? Culturally, the two nations are quite similar. Let's consider Australia. If I'm not mistaken, Australia's spending for Medicare for All is down to 10% of GDP. I believe it's even lower than Canada's. It's close anyway. But probably Australia and Canada are the two closest countries to the United States in culture. If they can do it, why can't we? Seems to me a President Bernie Sanders would be able to realize those particular savings. Now, he might not be able to do it if he stays with his own bill. But if he eventually goes with Jayapal's bill, with its 2-year transition period, he can probably get down to the percent of GDP level he needs to get down to by the 3rd year and realize all those savings, okay, I talked about. Why do we want him to get those savings? Well, it's not a question of whether the government can pay or can't pay. We all know the government can pay. It can pay for whatever it has to pay for. It can always afford it. It's a monetarily sovereign government. But it isn't healthy to have healthcare spending being 1/5 of the economy of the United States. It's a very important area. And yeah, 10% is not out of line, okay, or 11% of GDP is not out of line. But 20% of GDP is certainly out of line. And it should be one of our goals to balance spending far more so that the private sector can spend in other areas apart from the healthcare area. So that's what I would say about things. Now, there's a couple of side points, okay, that I wanted to add. Uh, Hang on a second while I add those things. So Susan Eldridge, who's probably here tonight, suggested that I take a look at the Jacobin article by Matt Brunig, who's a very good writer on Medicare for All and has been for years. And he's a very good writer on lots of other things too. I just don't like his views when it comes to the UBI, okay, and the job guarantee. He's not for those. But otherwise, he's generally very progressive. The first thing he saw when he got to Warren's financing plan was that one of the taxes in her financing plan was a head tax. It's this provision right here. Employers will be required to pay an employer Medicare contribution equal to 90% of their per employee healthcare costs in the year prior to Medicare for All's implementation. This will mean that initially some employers pay more than others, since that's already the case in the status quo. But over time, each employer's contribution will be gradually converged to the average employer Medicare contribution until every qualifying employer is paying the same amount per employee. Now, this only would apply to employers with more than 50 employees, 50 or more, and to independent contractors. They would be exempt from this particular requirement, okay, under Warren's plan. Okay, so Matt Brunig correctly points out that what Warren is proposing here, in ordinary fiscal language, is a head tax. It's a Medicare head tax, which is different from the normal Medicare payroll tax proposals. And he illustrates that difference, okay, by pointing out he has two graphs. The first one shows the difference in terms of employer-side taxes but paid by worker earnings to be level. But under the 8% employer-side payroll tax, the employer taxes paid for a worker earning $15,000 a year is $1,200, while the employer taxes paid for a worker earning $200,000 a year is $16,000. Under the $9,500 employer-side head tax, the employer taxes paid is $9,500 for both of the workers. So Matt correctly points out that is a regressive tax. And he gives us graphs to show that it is a regressive tax. He notes that Warren's team realizes this is an aggressive, does realize that this is a regressive tax. But he says the reason they're using the head tax is because they think they can trick journalists into declaring that this is not a tax, but a premium, since it is expressed in dollar terms rather than percent terms. On first glance, this might seem like a stretch that probably won't work, but it is a more plausible strategy once you consider that journalists are mostly very stupid, says Matt, and cannot evaluate policy claims on their own, relying instead on trusted sources and names, Warren being one of those names. Which incidentally reminds me that when Warren came out with her plan, oohs and ahs and hoo-ha's and all kinds of compliments from the likes of Ryan Grimm of The Intercept in a video he did for RHQ, and a laudatory article by Dave Dayan in the American Prospect as well, and a laudatory article in The Intercept, okay, by Addie Barkin as well. All of them took at face value the Urban Institute estimates of what Medicare for All was going to cost. This is ridiculous. None of them have even questioned that. And believe me, they're a lot smarter than that. Why wouldn't they question it? Why wouldn't both of them immediately see that these Medicare for All estimates that she started from are totally implausible? They don't happen in the real world, those kinds of estimates. Sahil Kapoor tweeted, new Elizabeth Warren finally reveals how she'd pay for Medicare for All. Taxes on employers, corporations, 1%, but plus revenue via war savings, immigration reform. Her advisors pegged the cost at $20.5 trillion. Urban pegs the cost at $20.5 trillion. Her advisors, okay, Urban, that neoliberal outfit, please. Contra Bernie Sanders, no middle class taxes. Well, I thought for a long time that Bernie said too quickly that there had to be taxes on the middle class. That's very unlikely. I don't think there have to be any more taxes on the middle class. I think Bernie's plans for wealth taxes and corporate taxes are probably enough to make up, how much did we say it was? 9.4 trillion or something like that. A 9.1 trillion over 10 years, by 900B per year. He certainly plans to tax that much. He's talking about revenue, of course, but he knows it's not revenue he needs. It's just the offsets. So the policy space, is still there. The revenue, or I should say the reserves, are taken care of by creation of money through the Federal Reserve. And Bruni points out that separate from the distributive problems of Warren's head tax, the two exclusions also make the proposal clearly unworkable and easily gamed. All companies have to do to avoid rather large head tax charges is to spin off workers into independent contractor status, or spin them off into firms with less than 50 employees that they then contract with for services. Once some employees start doing this, the average Medicare employer contribution will have to go up to keep revenue stable, and will push even more employers to restructure their labor into independent contracting or outsourcing to small firms. And at that point, the death spiral is off to the races. And Matt, of course, is completely right about that. That's what they would do to avoid this tax. And he points out the genius of the payroll tax, of course, is that it is unable to be evaded like this. Every dollar of income, even independent contractor income, is charged the same. No restructuring can save you from it. An excellent point. He says, while it's clear that Warren's permanent Medicare head tax is unworkable and bad, I do think a temporary head tax that transitioned into an employer's side payroll tax would work. To do this, you would start it off the same way Warren does, by requiring every employer to pay 98% of their per-employee healthcare costs prior to Medicare for All. And he goes then through this and he explains it. I'm not going to go into this. What I am going to point out is, why does Warren want to have this head tax in the first place? Because she wants to call it a premium. Employers will be required to pay an employer Medicare contribution equal to 98% of their per-employee healthcare costs in the year prior to Medicare for All's implementation. So they want to call it a Medicare contribution and not a head tax, because she promised no middle-class taxes. So as Matt explains, the head tax is a device to try to avoid people saying that she does have middle-class taxes in the form of the head tax. Now, I think she's greatly helped, though, through all this, if she gets rid of urban and she gets a group of people who will project the Medicare for All costs in a much more realistic way. She doesn't need that head tax at all if she's only got to make up 9.1 trillion. She can make that up with her corporate taxes and her wealth taxes the same way Bernie can. So I don't think there is a need for additional taxes. And I think after a while, that's going to become clear. And so I wanted to make it clear now. Now, I'm not going to go through two other very interesting articles. One was by Lambert Streether, my old friend at Naked Capitalism. And he did his usual very well written piece. And he read Matt's article, so of course he called it a tax. But he pointed to dependencies. He made the very important point that whether Warren can save the money from the three measures, okay, that are in yellow. In other words, from tax enforcement, 2.3 trillion, 0.4 trillion from immigration reform, and 0.8 trillion from the elimination of the overseas contingency operations fund, okay, from the military, which is a total of 3.5 trillion. Whether she can get that 3.5 trillion is dependent on the politics of the situation in other areas. It isn't really properly part, okay, of Medicare for all considerations. Of course, it does fit in with the idea that you shouldn't be earmarking certain taxes to pay for Medicare for all at all. What you should be doing is passing Medicare for all, passing all your other programs, and then considering how much you have to tax to contain inflation and design your tax package accordingly. That's the way things should go. That's the way they would go if we get rid of pay-go in the Congress, which means if we get rid of Nancy Pelosi in the Congress, or at least remove her as the Speaker of the House. That's pretty damned important to avoid the current kinds of irrationalities we go through, like this irrationality. Well, how are you going to pay for it? How are you going to pay for it? Well, we don't pay for the military. We don't pay for Medicare for all. We don't pay for anything in terms of specific taxes for that thing. We just put forward a tax package that covers everything sufficiently to avoid inflation. I look forward to the day when we can say, that's what we do. That's the way good government works, not this other pay-go crap. Okay. So Lambert points out the head tax and what Matt has to say about how that tax, okay, is evaded. Okay, and Lambert makes the helpful suggestion. Well, maybe Uber could set up a separate business unit to help companies handle the demand for turning employees into contractors that Warren's plan will create, or some Silicon Valley venture capitalist is licking their chops as we speak. Yeah. Yeah, Lambert knows how the world operates. And Lambert points to the transition period from Warren's white paper. Of course, moving to this kind of system will not be easy and will not happen overnight. This is why every serious proposal for Medicare for All contemplates a significant transition period. As I said in my last show, if Warren really does intend to go for a 5-year transition period, that is really going to up the cost, of Medicare for All over a period of time, because those transition costs are going to be heavy. They're going to be heavy the first 2 years under the Jayapal bill. They're going to be very heavy under the Bernie bill with a 4-year transition. But with a 5-year transition, we'll be continuously compensating people for, in some cases, the very bad work they did in the past. Now, I know all they were doing were taking some legal jobs, and I don't want people just to be put out on the street either. But nor do I want to show an excessive amount of solicitation for insurance investigators whose job it was to deny people coverage that they had bought through finding technicalities that enabled the insurance companies to deny their coverage and their claims. That was going on for years and years and years. That was a dirty job. It was not an ethical job. It did great harm. I am not about to feel too sorry for the people who did that kind of thing. But that's another consideration, and that's another matter. There should be a transition period. It should be reasonable. A lot of people who work for the health industry now will just be working for the Medicare for All program in one capacity, or other. 2 million people are not going to lose their jobs, as a result of this. All you can really say for sure, I think, is that in the insurance industry, there are 650,000 people who are working for them directly right now. Probably half of them will be absorbed by the Medicare for All program. The other half are going to have to find other jobs. But with Bernie doing a Green New Deal at the same time, there's not going to be a problem finding jobs, and even good jobs. There's going to be a problem finding employees. That's the problem we're going to have to face when the Green New Deal gets going. And Warren also says the transition plan will also grapple directly with the entrenched political and economic interests that would spend freely as they have throughout our history to influence politicians and try to frighten the American people into rejecting a plan that would save them thousands of dollars a year on premiums and deductibles while making sure they can always see the healthcare providers they need with false claims and scare tactics. And Lambert said, which is all fine, accepting the premise that the concerns of unions, individuals of private insurance, hospitals, people who work for private health insurance, and medical professionals have never been taken seriously before. But we'll need to see how long that transition period is, won't we? Given that Medicare for All is a long-term goal. So Lambert noticed, as I had noticed, as most everybody probably is noticing, because it's repeated so often by Warren, that Medicare for all is her long-term goal. We still got to find out exactly what that means, because it can't mean the same thing as the Bernie bill, even though she still claims that she's going through with the benefit side of the Bernie bill. So Lambert then ends by giving Sanders' view on the pay-fors, and that's a quotation from the interview he had with John Harwood that we've been over here a couple of times already. And also Lambert gives a list to 7 of the 10 options from the Senate site. I counted 10 as opposed to 7. But I think I rule out the premium options, because I think Bernie has promised, okay, they won't be premium, so I don't think that he's going to take those. He may have offered those as options, but I don't think he's going to push those. So I think it's going to be closing loopholes, the wealth tax, okay, the estate tax, making the personal income tax a more progressive tax, which is not going to hurt to the middle class at all. And then savings from health tax expenditures. In other words, what those are about is that it was possible for people to previously deduct their medical expenses from their taxes. Now those, in other words, there's no need anymore, okay, to deduct things, because people have no health care expenses under the Medicare for All plan when it's fully implemented. So there are going to be all those savings from it. And there's a little note left by Lambert, but there's this quote: "The bill provides a detailed proposal for how to achieve our end goal, but as economists and advocates have noted, the legislation leaves open a number of key design decisions that will affect its overall cost, and the bill does not directly incorporate specific revenue measures," unquote. And I think that's because Bernie doesn't really know at this point how much, okay, it is likely to cost. He doesn't want to get into arguments over cost. I mean, he's into enough of them already. He wants to simply stick as long as he can with the general point that we're paying for it already. And some taxes will have to go up, but people are going to save a whole lot of money. And he's absolutely correct. He's absolutely right about that. There's no doubt about it. He will only have to say more as a result of Warren's caving in and coming forward with this kind of proposal, which also puts pressure on Bernie to come forward with his own piece of nonsense on how it's going to be paid for, okay, in a way the press doesn't want to argue with. It's about not having arguments in the press over this and distracting further from the desirability of Medicare for all. One more thing, I don't want to go over the whole thing, but there was a very good article on Warren's bill by Dave Dayen, once again in the American Prospect. And I think we went over that last time to some degree. I did want to highlight one thing about it. The detailed plan will test the limits voter endurance. Let me highlight that for you. Detailed plan will test the limits of voter endurance. The Medium post clocks in at over 9,300 words, but the concept is quite simple. Figure out what it costs to pay for health care for the entire country. Figure out how much you can reduce that spending. Add in health funding that the government already pays for, and then make up the difference. Well, of course, it's not simply the government, it's all levels of the government, okay, already pays for. And figuring out what it costs to pay for health care for the entire country, well, you have to start with projections by CMS concerning what it's going to cost from 2000 to 2027, and then those projections are extended out further by Urban to 2028 and 2029 because CMS only went to 2027. So then you have to address the idea, is that 52 trillion even accurate? Is that even accurate? Can we even trust that particular figure? Now, what I'm saying to you is I think it's much more trustworthy to look at other cases around the world where single payer has been implemented and to say, what is the experience of these countries? What are they paying as a percent of GDP for their national health care spending? And we know this. We know this. We know it from the OECD figures. We know that it's sort of averaging around 10% or 9%, okay, of GDP. We know there are a lot of nations that are spending much less than that. Some 7%, some 6%. I think China is spending some very minuscule figure on that. But countries with extremely good health care, better than our own in terms of outcomes, like Australia and Canada and New Zealand and Japan, are spending much less as a percentage of GDP than we are spending now. I say, take some percent of GDP that they're able to do right now, pick that out as a target, and say, we're going to do whatever is necessary to get down to that. And that's how we'll figure out what the cost will be after the transition period before single payer. And we'll also develop targets for the transition period as well and figure out what that's going to be. And then we'll have figured out what it's going to cost to pay for health care for the entire country. And then we'll see how much of a difference there is. And by the way, it's not going to be 23 trillion. I'm sorry, 34 trillion. And it's not even going to be 20.5 trillion. It's not going to be any of that nonsense. That is nonsense. Okay, let me go back to my basic view here. And let me look at your comments and questions. I think I may have covered Warren by now. Okay, Steve Day is here. Hi, Steve. Nice to see you. Rob has joined. Hey, Rob. Margot Shepard's joined. Hey, Margot. Greg Mallet says, sounds like deficit spending if you ask me. Yeah, I did suggest we have some deficit spending. I don't want to do all our deficit spending just for that. I want to leave a lot of deficit spending for the Green New Deal. That's real important there. And Andrew Nargowala's joined. Hi, Andrew, and hi, Gary. Hi, Susan. Hey, Susan, how you doing? I used the Brunig and the Naked Capitalism articles. Byron Montgomery joined. Hi, Byron. Oh, gee, I didn't know I was your JG tutor, Byron. Thank you. Stephanie Smith-Udy says, sorry I'm late. Oh, I see I am below the horizon again, so I have to sit up. Sorry, excuse me. I got to look at my monitor. Devora has joined. Dale Weaver has joined. Okay, and Evelina Apont has joined. Hi. Dave Pilkington has joined. Hi, Dave. Susan has joined. And and Susan says that Matt, doesn't agree with MMT. No, he doesn't. And Nancy Blackmar says hello. Susan Eldridge. Sahil tweeted today that he was going to include Kelton in his next article on how progressives will pay for stuff. Good for Sahil. Evelina, sounds like your side point about Warren's Medicare plan is central to the counter argument refuting it, maybe rejecting it entirely. Well, certainly she'll have to tax a lot less than she thinks. Instead of a head tax, maybe get her head examined. That was very polite, Evelina. There are some people who would have said other things about her head, which I won't go into. Is Lambert an economist? No, actually, Lambert by trade is a computer software person, and a very, very good one. But he, like myself, has picked up a lot, of MMT. In fact, about Lambert and I and 4 other people, if I recall correctly, were the organizers of the Fiscal Sustainability Conference back in 2010. And after the few initial blog posts, the primary blog that was writing about the conference prior to it and just after it was Corrente Wire, which was Lambert's blog. He's the owner, of that blog. He's unfortunately discontinued it now, but you can still find it in the Wayback Machine. But there were many great blog posts, that appeared there in 2010, 2011, 2012, 2013, 2014, In fact, the first place that my series on the job guarantee appeared, entitled The Job Guarantee in the MMT Core, which was a 15-part series. The first place, that appeared was on Currenti Wire. It's still available now at daily costs. Evelina says, thank you for bringing up ethics and all of this. Sure. Steve Gonzo's joined. Okay, Evelina says, so exciting when all this gets started. Yes, it is. And she also says, central to your counter argument. I mean to say, yes, it is. It is rather central to my counter argument. She has estimated her likely costs, for Medicare for all, or the likely costs, for Medicare for all, far too much on the high side. And unless she puts in a ruinous transition period, she's not going to come anywhere near 52 trillion as a total for the whole thing. Nowhere near 52 trillion. I suspect that since she's going to be less economical than some others, she might come in at 40 trillion rather than at 34 trillion. Spending on it maybe 600 billion a year more than she has to spend on it due to the transitional costs. I'd guess something like that. Where Bernie can probably come in, and if he goes in the end with the Jayapal bill, which I think is what he's going to do, then I think he can come in at 34 trillion for it. Even with the 2-year transition period. That's what I think. Any more questions or comments? Is Bernie's plan cheaper? Well, her plan supposedly is Bernie's plan, except for what she's now doing, talking about her transition plan. When she introduces her transition plan, she will no longer be sharing Bernie's plan. That's going to make it different. That's going to mean she'll be legislating something different than the Bernie bill. And I believe her bill is going to be more expensive. Susan says, we need to get him to use the Jayapal bill. Yes, I think we do. But I think what he'll do on this is, instead of campaigning on the Jayapal bill, what he'll probably do is campaign on his own bill, keep on making the same kinds of appeals, but it's the Jayapal bill that will pass the House. And maybe his bill will pass in the Senate. And then the conference committee will go back to the Jayapal bill or do some compromise. So I suspect that's what's going to happen. But my central point here is, the sooner they can get down to 11% of GDP, the less will have to be spent on Medicare for all in the first 10 years. Now, in the long run, that's not so significant. As long as they keep the spending to 11% or 10% of GDP, in the long run, national healthcare spending is quite contained, and we'll be able to afford to spend. On other things as well, because we will have cut our national healthcare spending in half, and also covered everyone, and covered them well. It'll be great. So, Please share, like, and subscribe, especially when I put up the YouTube, which will be up fairly soon after this. And remember, please become a patron at www.patreon.com/Joe_Firestone. I really need some patrons there. Any other comments? Last minute comments. Susan says, yeah, Bernie must win. I think that it's almost a life and death matter for younger people that Bernie win, because I don't think anybody else is going to be successful in pushing and in getting the Green New Deal through. I don't think that Warren is going to be as vigorous at doing that. Okay, well, thank you for hanging in there. There are very few of you still left now, but thank you for coming. And thank you for hanging in as long as you have. I'll be back on Monday night. And so good night, and have a great rest of the weekend.